right, good evening, ladies and gentlemen, and welcome to this evening's debate. This has been a long time in planning and coming, and we're just excited to have you here joining us this evening. I'd like to welcome you on behalf of the Leavenworth-Lansing Chamber of Commerce, particularly Jen Anders, who is our president. Unfortunately, she can't be here this evening because she's on vacation with her two daughters. But the rest of the chamber, and particularly my governmental affairs committee, welcomed you. We're glad you could be here this evening, and we really welcome our two debate teams. Again, the purpose for this evening is to have a debate about the question: should the state of Kansas accept the Affordable Care Act's Medicaid expansion? This is meant to be a formal debate. Now, if you pay attention, probably learn something. Then you can race home and you can watch that other thing, which masquerades as a debate, later this evening. But here we're here to have a logical, well-informed, well-reasoned debate between the two sides of the debate. Let me introduce our two teams. By the way, I was advancing correctly. For the expansion, for the proposition, we are really pleased and thankful that we have representing the position of expansion. First of all, David Slusky. I hope I pronounced it correctly. As you can see, if you got the handout, he's a professor of economics. He's an interim chair for the Department of, I love this, the speech, language, and hearing. I love to learn how you match those two. Absolutely. His partner is Dr. Donna Ginther. She is the Roy Roberts and Regents Distinguished Professor of Economics and the Director of the Institute for Policy and Social Research. Opposing the proposal of expansion, we have two other eminently qualified scholars. First of all, Dr. Linda Gorman is the Director of Healthcare Policy Center, Independence Institute, and one of our state senators, Beverly Gossage, who not only is a state senator, but she also is the founder of HSA Benefits Consulting. Both are well written and spoken on the issue. So we are very, very privileged to have these four scholars, these four experts join us. A little bit about the format. I think some of you may have heard we were going to try to use an audience response system, kind of poll you, what is your kind of position for or against before, and then afterwards re-poll, see if we've moved the needle at all. Unfortunately, I'm technology challenged and didn't get that software working, so we won't be doing that this evening. However, we're going to start off as in most formal academic debates, you go on the team for the proposition. So David will start off first. He'll have 5 minutes. Then we'll go on the opposition. Linda is going to talk first. Then we'll go back over to the opposition, and then back to the for and against. So 2 rounds each side. Then in the next round, we will have the teams ask questions of each other. So the opposition will ask for the proposal 1 question. They'll have 2 minutes to answer. Then they will ask a question. They'll have 2 minutes to answer. And then we'll go a second round of that. Then we'll open up to your questions. Again, if you want to ask a question, please write it down so we can sort them, get them up here, see if there's any trends. I'll be asking the questions. Each side will have 2 minutes to answer those questions. And then to wrap up, to make closing statements, we'll give each of our debaters, again going back and forth, 2 minutes each to make their closing statements. Have I missed anything that you want me to make sure I cover? Thanks. All right, well again, welcome, and before I get started, let me just express appreciation to Kelly Butler and Jeanette Laby, my committee that helped plan these things. I want to appreciate the Heritage Center. I also want to thank Eric Price, our AV specialist. Rogue Creative is his company, so look him up. He does a marvelous job for us. And I'd also like to express my appreciation to my lovely wife, who is our timekeeper this evening. So with that.
We'll clap
David, turn it
Thank
over.
you very much. Great, thank you so much. It's really a great honor to be here, and it was a pleasure to meet many of you beforehand and hope to get to meet the rest of you afterwards. Before I start, I want to say that I'm here in my own expert capacity, not representing the University of Kansas nor the American Society of Health Economists. So Medicaid expansion and the ACA Medicaid expansion is the most studied policy in my entire profession. It has been studied over 600 published studies in the most recent count. And all of these make use of the fact that some states expanding and some states not expanding has allowed us to compare those two groups over time to try to figure out what happened as a result of the policy. Often we roll out a policy and we don't really have anything to compare it to, and that makes it very difficult to think about what this policy did and what else just happened at the same time. So I have a sheet here that I have out there, and I passed out to some of you as best I can. I've got more here. And what I'm going to do is I'm going to both walk you through the broad majority position on each one of these issues, and then I'm going to drill down into a couple of individual studies to give you a flavor of them. But what I want you to take away is not as much individual studies and more the broader consensuses in the entire academic literature here. So first, let's talk about health insurance and employment. Overall, the ACA Medicaid expansion increased the number of individuals with health insurance coverage. You might be concerned it's just crowding out private insurance, it's having no overall effects. Over 200 studies found positive effects on health insurance coverage, and only 13 found no effect, and no studies that I've seen have found reductions in coverage. On access and utilization of care, 184 found increases in access and utilization to care, and 79 found no effect. You may be concerned that Medicaid reimbursement rates tend to be the lowest of any kind of insurance and that providers won't take it. By and large, most of the studies are finding increases in access and positive effects on access. And finally, on employment, you might worry that this makes it less likely individuals will seek employment because they now have health insurance. 11 studies find no effects on employment, and 5 actually find a positive effect on employment. Okay, now let's talk about health. On self-reported health, where you ask people how they're feeling, 20 actually found positive effects, 19 found no difference, and very few, if any, have found negative self-reported health. On more measurable health outcomes, 21 find positive effects, 22 no effects, and only 3 find negative effects. On mortality, ultimately kind of what is the measure we care most about? We care about saving lives. I certainly do. 10 studies found decreases in mortality, and 9 found no effect. To drill down on one of those, a study looked at what's called the American Community Survey, which is the continuous census that happens between the censuses that we do every 10 years. Took that survey. The survey is hundreds and hundreds of thousands of observations, and then matched them up to Social Security mortality data, right? Because normally we don't know if you didn't fill out the survey whether you're still alive or not, but Social Security definitely knows whether you're alive or not because they don't want to keep paying Social Security after you're no longer alive. Additionally, we have cause of death information as well, so you can look at what individuals passed away from. And what the study found is looking at the Medicaid expansion population, which is generally the population with either less than with a high school education or less, or who's low income, found a 9.4% drop in mortality for the 55 to 64 age population. If you scale that to Kansas, that's 72 lives saved per year. So every year that we have not expanded Medicaid is 72 more lives lost. And again, these are individuals under 65. These are individuals who didn't get to retire, who didn't get to spend time with their grandchildren. And if you look at causes of death, it's all on internal causes that can be medically treated. Right? We're not seeing increases in car accidents or other kinds of external causes. We're seeing it on internal causes. Okay, now financial. Right? One of the most important parts of health insurance is to help you pay for your bills and not have to have a GoFundMe, not have to go into debt, not have to go into bankruptcy from healthcare. So looking at the patient side, 12 studies found positive effects on household financial circumstances, and only 3 found no effect. On the hospital side, remember the hospitals also like to get paid, uncompensated care went down substantially. And some of these studies also merge with credit bureau data, so we're not just asking people, we're actually directly looking at credit bureau reports and found $1,000 less going to collection. Finally, on the cost of this. So the ACA has 90% of this paid by the federal government in perpetuity, and many states have actually found that even that 10% is offset by less spending on other programs and by increased tax revenue. In 2021, the American Rescue Plan actually further incentivized expansion by raising the amount of traditional Medicaid the federal government is already paying by another 5 percentage points. This is going to bring in $370 million to Kansas of federal dollars, in addition to the 90% for Medicaid over 2 years. This was supposed to end March 31st, 2024, but actually was just extended last year through March 31st, 2025. So we are encouraging you to support Medicaid expansion for all the reasons listed on the handout. Thank you so much.
Thank you. Linda.
I got to talk fast. Thank you. Does this change the slide? Right.
I think you invert it. There we go.
Nope.
Flip it, flip it. Yeah, sure.
Ah, okay.
Here. Hold it this way, and there we go.
I just wanted to start out by reminding people that we are here to talk about whether a policy is a good thing or not. And so we have to consider a lot of different things, and you have to consider what your policy aim is. And in my case, it's I want people to be able to buy the health care that they need and they want at a price that they can afford. And my question is whether expanding Medicaid in Kansas moves us towards that or away from that. Incentives matter a great deal. Medicaid is a program with a peculiar set of incentives, and I think Professor Slusky put it perfectly in one of his papers when he said the effectiveness of expanding access to means-tested public insurance is, quote, context-dependent, unquote. So, the first thing I want you to note is that coverage is not necessarily care. If coverage is what you're looking at, that doesn't mean that people are getting care. And let's start out then with, is Medicaid coverage expanding health? We had a lot of studies cited here beforehand. The question is, how accurate are they at looking at health? If you have different state comparisons, you have to take into the fact that marriage rates are different, car crashes are different, drug overdose problems are different, and none of these is included in these kinds of comparisons. So the comparisons are kind of sloppy. I like some of the individual looks, like the Oregon Medicaid experiment, which was kind of limited. It was 6,000 people in each arm. It was a lottery, and it tracked for 2 years people who randomly got Medicaid and who randomly didn't. Now, it's not a random sample of the population, but it's as close as we have. They find minor health benefits. People did better on a depression screen, but there were no physical health benefits, really, that they measured. Possible reduction in HbA1c, but it wasn't clinically, they didn't see any difference. Then we have the Rand Health Insurance Experiment. That's an old one. It's from the 70s. It's probably the most complete social science experiment ever done. They had a free care arm as well as 6 different kinds of coverage, and they found out that free care really didn't help health that much. These are very careful studies. Then we have who's changing into Medicare. One of the things you have to think about in policy is that when you give people free care, they work hard to get it. And so what we're seeing in a lot of studies is that people are dropping private coverage among college students, women near retirement who want to go on to Social Security at 62, the near elderly, and some adults aged 50 to 64. They will drop. There's one state that's gotten out of Medicaid-like programs, and that was Tennessee in 2005. They cut their Medicaid program way back because it was ruining the state's finances, and 30 to 40% of those who were dropped went on and got insurance. The problem with Medicaid is it was designed for the seriously ill and disabled who cannot help themselves, and that is why there is no payment, and that is why it has a huge, it covers everything you can think of, transportation, aspirin, you name it. So the incentives and the context for Medicaid is for the disabled people who can't help themselves. And now they're proposing to expand it to people who are able-bodied working people. And so the incentive structures are very different. And I'm going to screw this up, I know it. Okay. So people who don't have coverage can get coverage through a variety of channels. I'm just listing some of them there so that you know that they exist. There are other routes to get standard coverage. And this may be one reason that the studies of health give kind of equivocal results, because people are pretty healthy and they are pretty much getting care from other ways, if you are not seriously ill. So, to the financing, keep in mind that whatever numbers you're quoted about the cost, they're probably wrong, okay? Typically, enrollment has been 2 or 2.5 times what the experts predict, and right now the cost is about $7,000 a person, according to MacPac, and that's up from what they said it would be, which was $4,000 a person. Here's an example of how much people use. I've got 1 minute, I'm dead. All right, here's an example of the kinds of things that people do when they get free care. This is an emergency, this shows differential usage of emergency rooms. Notice that people with free care and who have to pay for care use emergency rooms about the same rate. But down at the bottom, if you're not paying, you're more likely to go to the ER for a headache. And the reason is, it's open 24/7, it's free, all the tests are in one place, and why should you drive around? So here's Economics 101 on Medicaid expansion. Okay? When you take a whole bunch of people, because of the expansion, and you dump them into a medical system which you haven't increased the supply for at all, you can't train more doctors tomorrow, you can't build more hospitals and everything else, then what you get is shortages. And Medicaid is characterized by shortages. Long waits for appointments, very difficult to get advanced care. They had to sue to get hepatitis C cure in many states, and so it's not a good program for the healthy.
Please. Sure.
So, I know, I've got it. So utilization, wow, some of those studies that she quoted were older than me. The RAND study in particular was pretty dated. The Oregon study is very interesting because it is an experiment. And they did find that, it was covered for 2 years, but it affected not only health, it didn't have necessarily an impact on the health in the 2 years that they were studying it, but it stabilized the household's finances. And when you stabilize a household's finances, they have fewer unpaid bills, they're able to go to work, and they have overall improved mental health. So I often call the Affordable Care Act the full employment for health economists like David and me. It gives us a lot to study. I'm going to go through Linda's arguments, and then I'm going to touch on some of the arguments in our handout. Coverage is not care, but according to a literature review from the Council of Economic Advisors in 2021, utilization of health care did increase in states that expanded Medicaid. Oregon, I've already talked about, it improved financial outcomes. The RAND study, again, the 1970s, the world and the economy has changed. I don't think that this study is relevant for today. College students were covered under the Affordable Care Act. It was part of the expansion. So they're not buying insurance policies. They're staying on their parents' policies until age 26 so they can go to graduate school, so they can get training and get jobs and get employer-provided health care. Medicaid, they argue that people can get coverage from other sources. I have a friend of the family who took her daughter who was having a reaction to an illicit drug that she took. She went to the Lawrence Memorial Hospital and was turned away. They wouldn't admit her. She had to go to Topeka to get care. So while there may be other opportunities, people fall through the safety net. And providing them her health insurance may have helped her treat her substance abuse disorder and provided her with a new lease on life. The costs, we can argue numbers every day. You're going to see so many numbers spinning around your head. What we've seen from the research is that the state budgets are stable. It doesn't really increase taxes. It doesn't take away state expenditures on other things. And the reason they're stable is because we're paying for it anyway, which is why I want to talk about the unexpected consequences of not expanding Medicaid in this state. First of all, we did a study in 2022, and we showed that Kansas didn't expand, but state expenditures on Medicaid, on CanCare, did increase, even though managed care was supposed to keep our costs down. Furthermore, because we don't expand Medicaid, the amount that we are spending if we are privately insured has increased. Between 2014 and 2028, total spending for privately insured residents in the state of Kansas have increased about 19% compared to 17% in other states. In particular, health insurance premiums for families, me, my kids, my husband, they've increased 77% in the state of Kansas. So you may not have federal health insurance through Medicaid today, but you're paying for it for higher costs. Finally, we've seen that those with private insurance are much more likely to be going to the hospital, 10% more likely. Why? Because the hospital has to pay its bills. So if your case is on the border of you being hospitalized or not, you're going to be admitted in the state of Kansas. Finally, I would argue that we looked at how, tax levies for counties with hospitals. We didn't find an overall increase in property taxes, but we did find a mill increase of about a third of an increase in the mills going to hospitals to keep those hospitals afloat. All right, and now since Medicaid was expanded, we've had 6 hospitals in the state close, mostly in rural Kansas. And furthermore, we have 60 hospitals that are on the verge of closing or scaling back operations, meaning that people out in the western part of the state are not going to have access to health care. So overall, we've had increases in taxes spent on hospitals to keep them open, and we've been paying for it regardless. We should take that 90% subsidy from the federal government. Current Medicaid is 60-40. Why can't we take 90-10 and improve health for everyone?
Thank you. Beverly.
First of all, thank you all for being here, and let me just say I'm the only non-economist on this panel, but I am a health insurance agent, and I help people every day for the last 20 years try to find affordable health care. One thing I do want to mention as a senator that I chair 5 of the different health committees in the state, I can tell you numbers as of this morning, which is 236 Kansans are on Medicaid currently. That's about 529,075 Kansans that receive some form of subsidy through Medicaid. That's 1 out of every 6 Kansans are currently receiving some kind of Medicaid services. What was Medicaid intended for? It was intended for low-income children, pregnant women, low-income families, seniors, low-income seniors, and then the disabled. We want to keep that purpose. That was the original purpose. We want to prevent them from ballooning it out and causing Medicaid to go for more people than it was originally intended. I want to just share something with you real quickly, and I'll try to do this fast. Don't know where my slide starts. Let me see. I think Linda, I'm buzzing through yours, I think. Wish my eyes were better. Is that my first one? Okay. So let me tell you what happens if you go to the ACA and you want to buy a policy. You call somebody like me that's certified on the ACA. The first thing I'm going to ask you is zip code, age, male or female, which really doesn't matter, but we have to put that in, and your income. Why is income so important? It's because that's what everything that the ACA was built upon. So it has kind of a cliff. It's based upon zero, whatever is considered zero, so the poverty level. Poverty level in Kansas is about $14,580 for a single adult. So we know that about 80 to 85% of all Medicaid expansion folks were able-bodied adults with no dependents. So I gave an example here of a person that's in Leavenworth, 66048, 25 years or 27 years old. It was mentioned they go on their parents' plan. That depends. If mom and dad's plan means it's $300 a month to add a dependent, they'll probably go on the exchange. So of this person, when I put in 14,580, what you'll see, and these are actual screenshots that I did today, is this person has a couple of options. So I'm so sorry. Can I move that closer? My eyesight is not that great. It's so small. Okay. One of the options that they have is what is called an advanced premium tax credit and a cost-sharing reduction. You only get cost-sharing reductions if you're in a silver plan, and the silver plan is the one that's going to give you that because it's going to reduce your out-of-pocket. Lower deductibles, lower out-of-pocket. So first thing you're going to see here for this person is that they could get a very low cost for their doctor's visit. Their prescriptions could be zero. Mental health, there's no charge for that. No premium for this particular plan, $100 deductible. Now, our governor has been going around the state saying, well, what about a single mom with 3 kids? Well, that's only about 15% of the people that have dependents that are on Medicaid expansion, but what about them? So, by the way, for the 27-year-old, here's another plan that's about $3. If you'll notice, primary care physician visits are at no charge, very, very low cost. So I took the same person, and here's what happens. Go back to the mom in a minute. I am certified in licensed in about half the states. So when I help people get a plan and their state expands Medicaid, then this is the phone call I get. Wait a minute, I got this letter, congratulations, your state expanded Medicaid. Do you want to keep the plan you have? This is what they would see, $369 or $380. Well, that's not my plan. Wait, $7,000 out of pocket. Beverly, this is not my plan. I'd like to keep what I have. If your state expands Medicaid, all of your subsidies go away. So it's either that or you're forced onto Medicaid. Now, I had a young man who was in a plan like that where he was paying zero premium, decided to go to grad school in Colorado, called me and said, could you get me that same plan I'm on right now? I'm working part-time for my dad. And I said, as long as you're making less than $14,500. Oh, you moved to Colorado. Then no, I cannot. They expanded Medicaid. I'm afraid your only choice is to go on to Medicaid. Okay, how do I get on that? Helped him enroll. 2 weeks later, I got a phone call that said, I can't find a psychiatrist within 50 miles from the university that will help me get my ADHD medication refilled.
Thank you. Thank you for the first round. Now we'll go to the second, which is each team asking questions. And we'll begin by the opposing team asking the first question. So, yes, the answers are 2 minutes. So do you guys, Beverly, Linda, you have a question? Yeah, you have a question, yeah. You have a question for
Yes. Okay, my first question is, what would you say to the current Medicaid population who are needing chronic care, who are already finding it difficult to get an appointment with a specialist, as to why we should prioritize able-bodied adults over them?
2 minutes.
Okay. Senator, thank you so much for the question. I don't think it is an either or in this case. I think what I could say to them is, I found a way to help a lot of other people who are in difficult situations like you are by getting a lot more funds from the federal government to do so. Meaning that the individuals who are currently on Medicaid are not directly affected in the same way by expanding Medicaid to other individuals. States have been expanding Medicaid eligibility since the start of Medicaid in the 1960s. Arizona didn't even have Medicaid until 1990. So this process of slowly expanding the social safety net as our economy changes, as gig work changes, as attachment to the labor force changes and the type of work changes, we have been tinkering and expanding and working on this for generations, and that's partly a function of a system where we can't step back. Many other countries around the world have done very different things with their systems. In America, we do this by patchwork. We do this by piece and little subpopulation here and there. The state certainly has challenges with Medicaid, as every state does, and I support all the initiatives that the state is trying to do to improve those, to reduce waiting lists, to reduce paperwork, to make eligibility more straightforward and easier and less burdensome for individuals. These are all great initiatives the state should do and should keep doing. And I would actually also even say that a larger Medicaid population in the state would increase the efficiency of the government in there, because you'd have a larger population in that program, right? A program that helps very few individuals is harder to have economies of scale in a program that helps more individuals. So I don't think it's a prioritizing of either or, because this is not saying to individuals who have Medicaid, we're going to roll back your coverage so we can move it to somebody else. That's not this. This is a way of expanding Medicaid to other individuals who don't currently have it without directly affecting the ones who do. Thank you.
Thank you. And your question?
So, Senator, I want to talk about your example. Because my understanding, and I want you to correct me where I'm wrong here, was that your example is for someone making between 100 and 133% of the federal poverty level who is on the subsidized exchanges in non-expansion states, but would be Medicaid in the expansion states. But wouldn't an individual making under the federal poverty level, my understanding is that individual does not currently get subsidies at all, and so would go from unsubsidized coverage on the exchanges to being eligible for Medicaid. How is that different from your understanding? Or what am I missing here?
That's my question. Okay. Thank you for the question. I'd be happy to address that. In Kansas, we believe that if we're going to give you health care welfare, then you need to work. If you're able-bodied, you need to work, at least at the poverty level. So that was the way the original ACA was written. That's why it stops at the poverty level. If you don't make at least the poverty level, then it's considered health welfare. So yes, if you go to another state, yes, you can get subsidized, but that's the whole point of Medicaid expansion. It's going to hurt the people who have a private plan that we don't pay anything toward. We as the state of Kansas, it's not going to come out of our state general funds for somebody who's on a plan like that. And so what I encourage people to do is I look at what we do in the Senate, and we have Representative Neely here today also on the House side. And we look at barriers to care. So are there barriers to employment? What are we doing? Are we keeping people on too long onto other kind of welfare subsidies that could go ahead and get a job? Tell me anywhere in the state of Kansas you don't see help wanted. Yeah, we need help for you to come and work at our facility. You know, if you just work 12 hours a week, 24 hours, $12 an hour, 24 hours a week. That's Wendy's, that's their day one, you're gonna make $12 an hour. That's $14,800 a year. So we would encourage people to get a job. We wanna make sure that we're not standing in the way of that or writing rules or regulations that are keeping small businesses and other business owners from getting the employees they need. Everybody's looking for employees. We want to see people get a job.
And opposition team, do you have your second question?
Second question.
Please.
Since we're doing this patchwork, I'd like to know what your policy goals are. When is enough enough? How much money do we have to give people who are suffering stress and say that that's a health care program? Are we going to end up with a British system where anybody who's resident in the country gets health care paid for by the taxpayers? They give lousy health care. And so I'd like to hear what we can do about that and where your end point is, because otherwise I think they're just talking about single payer.
Well, my son broke his arm in Australia. We had to pay for it out of pocket. He broke his arm earlier here in the United States. It cost us more with health insurance to get his arm, to pay for his arm in the United States than it did under a single payer plan. So when you say that single payer is horrible, my experience says otherwise, that you provide subsidies to people. Now, in terms of what is enough, right? So Senator Gossage argued that, we need people to work. Well, we're out of workers in the state. I'm a labor economist. Nobody who can work is not working in the state of Kansas. So, and the Medicaid expansion states have also shown that people don't stop working when they get health care. In fact, in some cases, it increases labor supply because people are healthier and they can go to work and be productive. If they have mental health issues or if they have other physical health issues that are untreated without health insurance, they're not going to be as productive in the labor market. So I don't see how there is an issue with expanding Medicaid and all of a sudden our workers will disappear. We are at full employment in the state of Kansas. There's nobody else. I mean, there's probably 1,000 jobs for every unemployed person in Johnson County. right now. We're full. We've got as many jobs as we could possibly want, and I don't see any evidence that people who get Medicaid will stop working. In terms of what's enough, is it enough? There are 72 people per year who died because of lack of access to health care. You take those 72 people, times it by 9 years, that's over 600, it's close to 650 people. The value of a statistical life is $11 million. We're talking about $7 billion of lost life in the state of Kansas by not expanding Medicaid. Is that enough for you?
Is that your second question, or?
No, that was the answer. Do we have a second question? Yeah.
My second question is about work requirements in Medicaid expansion. I just wanted to ask what studies you were aware of states that included work requirements in their Medicaid expansion, and what the impact of that was on enrollment, on employment, and on utilization of health care.
Yeah, well, first of all, work requirements were put on hold by the Biden administration, which brings up another point, which is when you expand Medicaid, basically the federal government is controlling 20 to 25% of your state budget. They can at any time say, you may not drop any people from the Medicaid rolls, which is what they've done. A lot of people are on Medicaid, and therefore they shouldn't be on Medicaid, but Kansas is not allowed to clean them out. So when you expand, you're ceding control. In terms of work requirements, it's really interesting that all of a sudden this has devolved into a labor force discussion. Really, this doesn't have anything to do with labor. Most of the people that are uninsured are working, some are not. We don't know how much because they use EITC or something. We don't know how many hours they work. But most of these people are able-bodied and healthy, and they're already working. If they're not working, they're living on public assistance or on their parents or something else. This isn't about getting people to work. This is about whether you can afford to change Medicaid from a program that mostly put people on it because they were disabled or extremely frail and poor or they're pregnant. Whether you can afford to say, okay, it doesn't matter, we're going to do income testing now. And we're going to let everybody on depending on their income. This is a very slippery concept. It is very hard to find out what somebody's income is. People go in and out of the labor force, they work for a while, they take vacation for a while, they lie about their incomes. It's really hard to tell. And so states have been very bad at administering this program. One reason nobody even bothered to clean the rolls was the Biden administration was just flooding tons of money in. But by putting it on income, you make it a counter-cyclical program. This means that when tax revenues are really low, everybody who's not employed is going to be on Medicaid, and your expenditures are going to be very high. This is causing huge budget problems in states like New York and Colorado who have expanded Medicaid. The budget shenanigans that are going on there are worrisome. They're hiding debt all over the place. They're rolling their debt over and stuff like that. So I would say there are a lot of things to think about here, and it doesn't have anything to do with labor force.
Kelly, do you have questions? Yeah.
Anybody else has questions?
Okay. First question from the audience. How does this expanding Medicaid affect the people on the 10th year wait list for the DD Medicaid waiver? These people seem to pay the price and sent to the bottom of the priorities list over and over again. Please. Can we respond also?
It's
Yeah,
perfect for
absolutely.
me because of the fact that I chair the IDD waiver committee. And I'm thankful to tell you that when I was at a recent Allegan National Conference of State Legislators meeting, I met with my Missouri counterparts, and they have been able to pare down their list by declaring a separate waiver that's a partial waiver. This should get the majority of our people off the list, but I can tell you this, Medicaid expansion does nothing for the disabled, the intellectually disabled or the disabled. It's only for able-bodied adults, particularly with no dependents. However, I'm pleased to say, like I said, I'm working with Kirk Matthews, Assistant Director for Medicaid on the Missouri side, for us to expedite getting people off of the waiver list. It's for the first time, I've been on the committee for 3 years, the first time I'm chairing it, we're going to see progress.
Please.
So the IDD program has a huge wait list in the state of Kansas, and it's deplorable. About 5,100 people are on the wait list, but it's two separate programs. So there's the intellectual and developmentally disabled wait list. There is a waiver. The wait list is way too long for 10 years. Interestingly, Missouri has Medicaid expansion, and so the Missouri example seemed ironic to me. I do think that the state could do a better job with the IDD waitlist, but Medicaid expansion is talking about 140,000 of your friends and neighbors who need health insurance and who get turned away from hospitals, or get triaged in emergency rooms, or leave their diabetes care untreated, or like a friend of mine didn't follow up with chemotherapy for her bladder cancer and it came back, right? I mean, these are life and death circumstances that if you don't have coverage, you cannot get the care you need. So I think that while I'm hoping that the state does more for the IDD populations, we have 140,000 people in the state who may lose, some of whom have chronic conditions that will lead to faster rates of mortality or greater rates of sickness, and some of who have acute conditions and need care now. And so as a humanitarian, as a person who cares about my neighbors, I want to see those people have access to health care coverage and be prevented from going into bankruptcy.
Thank you. Yes. And then you guys can have another 2 minutes too.
One of the scariest meetings I ever went to was in Colorado, in sort of the western slope, after they had expanded Medicaid and people were there. It was a listening session for the State Health Care Commission. People on Medicaid were furious because they had no access to specialists. This isn't about access, because what happens when government runs a program is they pay way under cost, and so people cannot afford to take them. One of the reasons hospitals are failing is that Medicaid pays 82 cents on the dollar, according to the American Hospital Association. And what governments always do is prioritize the biggest mass of voters. And believe me, that's not the disabled people. And so that's why you want to keep Medicaid focused on people who seriously need a lot of health care, because it makes it easier to manage. There are other ways you can provide health insurance and coverage for basically healthy people. There's a group in Houston, for example, Dallas, who have illegals who are on dialysis. Illegals are not eligible for Medicaid, and they're about 16% of the uninsured population in the United States. So even if you expand Medicaid out the wazoo, you will not cover everybody, right? And what they have done is gotten together a bunch of charities. They are buying exchange healthcare plans for these people. They're just paying up and getting donations for premiums. And so the real question you have to ask yourself is, when they passed the ACA, remember, states were going to be forced to expand Medicaid to 100% of the poverty level. The Supreme Court said no. Okay? And so at that point, if it was really seriously about getting coverage for people, what the federal government could have done was vote to say, okay, we're going to give exchange health insurance coverage subsidies down to whatever the state's Medicaid income limit is. Now, why didn't they do that? Very simple process, would provide better care because it's more tightly focused on those kinds of people. They didn't do it because they want to move everybody towards single payer, where Medicaid and Medicare are controlling more than 50% of the care, and they start telling you what to do.
Another 2 minutes.
I want to get to the rest of your questions, so I'll try to make this really quick. I want to refocus this on what the debate we're having is about. We're having a debate about not what the ACA should have done or what the ACA could have done. We're not having a debate about other parts of the Medicaid program in Kansas, even ones that are tragic and deplorable. The debate is about whether Kansas should accept the 90-10 in perpetuity and the shorter additional incentives and expand Medicaid for individuals making between the current Medicaid threshold up to 138% of the federal poverty level. That's the conversation we're having, and I want to try to refocus us back toward that. We don't get to debate about whether we're going to pay the taxes the ACA did to fund that. That ship has sailed. We can debate about what else the ACA should do or what it could have done or what federal reform should look like. I teach a whole course on this. I could do this all day and all night. But right now, I want to focus us back on the current question about the ACA's Medicaid expansion.
Thank you. All right, next question. How long does the federal government pay 90% of the expansion costs, and what happens when that time expires? Does the state of Kansas have to pay that balance of money previously paid by the federal government, and if so, for how long?
Everybody remember the filibuster, right? You know, Mr. Smith goes to Washington and talks for a long time, right? So the Senate can pass bills through certain mechanisms under the filibuster, or they can actually get 60 senators, and then it's law forever. This is one of those laws, right? Before Teddy Kennedy died, they had 60 senators and did this. Until the federal government changes the law, the 90-10 match is in the law. So that's in perpetuity. Additionally, nothing is stopping Kansas when expanding Medicaid by passing, I think it's called a poison pill, provision in the bill that says if the federal government were to ever go below 90-10, we are going to stop enrolling new individuals and disenroll everybody as quickly as possible and wind the program down. State of Kansas could do that. And then we have to ask ourselves, would we rather expand Medicaid while there's the additional federal incentive for another year and a half, while the 90-10 match exists, or would we rather not? That's the choice in front of us that we're talking about in this conversation.
Thank you. Please.
Law or not, if the federal government says that we can't pay 90% anymore, they're not going to pay 90% anymore. They just put that into regulations. We saw where we had regulations that said short-term medical plans could go up to 3 years. And now the Biden administration said, 4 months. So things can be changed by executive order. We've all seen it happen. Remember, a cell phone and a pen. A couple of things I would like to address that have been brought up, and that is about the Medicaid expansion population. Statistics show us that of that population in the states that have expanded, on average, 55% of the Medicaid expansion population report zero income. 70% in some states have reported zero income. Again, do we want to give health care welfare to people who won't work? And then the other thing I would say is that in the state of Kansas, thankfully, we have pared down the IDD list from 6,100 as it was a few years ago. It's now 4,500. Still too big, but look forward to next year. So I'm excited about some things that we're going to get done. And no, Medicaid expansion was not expanded by the legislators. In Missouri, there was a referendum that was put on a ballot. And imagine if I came to you and said, do you believe that low-income people should have access to health care? Oh, then you should expand Medicaid. Oftentimes we see, we see ballot referendums and things like this put out. We see hundreds of thousands of dollars spent on trying to expand Medicaid in Kansas over and over and over again. But Kansans are too smart for that. And when they talk about a ballot proposal, some of my friends in Kansas were like, God, I wish I'd realized what Medicaid expansion really was. Did you vote for that? I'm afraid so. I mean, I thought it was, I didn't think it was going to be that. I didn't know how many people it was really going to hurt.
Okay, next question. Our hospital here in Leavenworth, our hospital, Cushing, thank you, getting old. Our hospital, Cushing, closed due to uninsured charity care. Would the ACA have prevented that?
So there's a really great literature review on that summarizes the effects of the Affordable Care Act on coverage. One of the things that this literature review by the Council of Economic Advisors shows is that uncompensated care falls dramatically when you expand Medicaid. And this is a cost that our hospitals have had to bear for 9 years. Also, in our report that I was quoting from. So there is a provision of the ACA that reduced the amount of money going to hospitals. There is also a proposal that that reduction may be reduced even further. So our hospitals are really financially unstable without Medicaid expansion, because the idea was you cover these people with insurance, they have care that is that the hospitals can bill, and therefore that balances out the changes in the costs of the drop in the amount of money going to hospitals from the federal government. So another thing is we need to understand that this uncompensated care happens to anybody who doesn't have health insurance, 140,000 people. And so this hospital in Leavenworth closed, hospital in Independence closed, lots of hospitals in western Kansas, and those hospitals mean that you're going to have to drive hundreds of miles if they close to find health care insurance. If you have a heart attack, if you have an emergency, if you have an accident. Is that what we want for our state?
Thank you.
Okay. This is why hospitals are closing. Notice we've had these closures since the ACA. I can see it, it's fine, thanks. And when you see a new hospital built, where is it built? In the suburbs where people are privately insured. Why is it built there? It's built there because while my opponents only talk about Medicaid unreimbursed care, that's people that don't have insurance and don't pay. The other issue is that Medicaid doesn't pay cost, doesn't come close to paying costs. And so here are a couple of figures from studies where they're looking at IRS filings from community hospitals. And as you can see, that the loss from average compensated care costs decreasing under the Affordable Care Act and Medicaid expansion was $1.11 million for the average hospital. But the cost of having more people on Medicaid, which paid less, was $1.62 million. So basically what we're saying is expand Medicaid, we're going to lose money on every patient, but hey, guys, you can make it up on volume. And I don't think people understand how big the payment differences are. So here's another slide. This is from Millman, which is an actuarial firm, and it's showing the ratio between commercial payments and Medicare fee-for-service rates. Medicaid is typically lower than Medicare fee-for-service rates. This is how much difference is, twice as much, half as much. This is why you cannot get care when you're on Medicaid and Medicare. If you're on Medicare, good luck getting a doctor. You might see a nurse practitioner. Medicaid is worse, all right? So this is something you really need to think about. In order to pay enough to keep these hospitals open and to keep a standard of care in the U.S. where we have a lot of technology to work with and good drugs, as opposed to some place like Canada, which, believe me, is a mess right now, you're going to have to pay for it. But we're already running enormous deficits and enormous overspending on Medicaid payments in states, New York being a case in point. And so if you were to raise them to this level for everybody in the program, you would be broke instantly. So that's why expansion doesn't necessarily do anything but close hospitals.
Okay, last question, and then we'll go to your closing comments. What will happen with state-passed prohibitions on abortion funding if Medicaid expansion was adopted? Who wants to take it first? What will happen to state-passed prohibitions on abortion funding if Medicaid expansion is adopted?
I don't think you're actually going to hear much disagreement here. Nothing. I think the federal and state prohibitions on public funding of abortions would apply here also. So I don't, I mean, you could have a whole different evening on abortion if you'd like. I'm happy to come to that one too. But I don't think it's going to, I don't see a big effect here.
Okay.
I just want to address that. I don't see that either. But one thing I would like to go back to is When we studied the other states that have expanded Medicaid, it never saved a single rural hospital. One thing that we did with Senate sub for a House Bill 2208 last year was that we passed the Rural Emergency Hospital designation to allow rural hospitals to have fewer beds to be able to receive federal health care reimbursement. Another thing we did was implement the Rural Hospital Innovation Grant Fund, and then also the Certified Community Behavioral Health Clinics to help them be able to take more mental health patients.
Thank you. All right, our final round is your closing statements, 2 minutes for each of the four of you, and we'll start with the Ford debate side.
Thank you again. You've really been a great audience, and it's been a pleasure to be here. I actually want to just start with applauding Senator Gossage and all their work on keeping rural hospitals open. Healthcare policy is much broader than just the ACA Medicaid expansion, and it's nice to find other areas where we agree. I want to step back and think about what the ACA was trying to do. The ACA had 3 goals. Cover everybody, not raise the federal deficit, and leave employer-sponsored insurance as intact as possible. And within those 3 goals, you end up with the system we have here, where you're taking an employer-sponsored insurance, you're doing small tweaks around essential benefits, but not the kinds of tweaks that President Clinton and other previous reforms are working on. You take individuals who have stable jobs, have stable incomes, and you're giving them the kind of subsidies that those of us who are privately employed already have through our employer and through the tax savings from our employer. And then you're taking the low-income population that doesn't have particularly stable income or necessarily stable employment, or already has a medical condition that is preventing them from being able to work full-time or work in the way or the manner that they wish they could. And you're taking the existing state Medicaid programs and expanding those eligibility of those in a tradition that has gone on in America since the founding of Medicaid in the 1960s. The coverage expansions to children, to pregnant women, this has been a long-standing federal and state process. That was the goal. And then you have the Supreme Court saying that actually states can decline the Medicaid expansion funding without losing their other Medicaid funding. And now you have a population making under 100% of the federal poverty level. Everywhere between 0 and the $14,000 number that we mentioned earlier has no access to subsidized health insurance, none. If their employer doesn't provide it, they don't have the tax benefits we have, they don't have the bulk savings we have, they are stuck in a situation of not being able to afford health insurance. And this is a way to take federal funding and expand an existing state program to give those individuals health insurance.
Thank you.
More slides, I think. One of the things we haven't talked about here, a couple things. First of all, it's a big change. I want to emphasize again, it's a big change when you let people be eligible based on their income. We keep trying to downplay that. That's a huge change for this program. It's something that needs to be carefully considered. The other thing that needs to be carefully considered is every time you expand the government programs, particularly Medicaid, you increase the cost for the private sector because Medicaid and government finances the program by dumping costs onto the private sector that you can't see. Hospitals are taxed at 3% every time it generates a bill, so so the state can increase its federal Medicaid matching funds. You get favored pricing requirements for drugs. As you can see, you get an increase in your prescription drug prices when Medicaid market share increases. You get slower purchases of medical technology, lowering reimbursement costs, and so forth and so on. Another thing to think about is the effect on the state budget. I'll just leave you to read that. While I point out that what we are not talking about here is an insurance program. There is nothing about Medicaid that's insurance. There's no risk adjustment. There's no risk offlaying to somebody else. It's simply a program that provides free care for certain people. It makes sense for a certain population. It doesn't make sense at all for able-bodied working people who can, change their income as they feel it. And yes, it does reduce financial, instability, but what about the people that have to pay the taxes that support it? Now you're talking about this as free money, we're already paying taxes for it. Really, there's a tooth fairy. The money comes out from under somebody's pillow. We're running huge deficits in this country. Eventually, the federal government is not going to be able to pay for these programs. And so I think it's very wise not to build your state healthcare system, particularly when you've got private payers, on something that the federal government can take away immediately. In Australia, people try to stay off the public system as much as possible because they hire doctors that lose their licenses in Oregon to go work in Australia. There's famous case about that. Everybody that can buys private coverage in Australia. We haven't had a two-tier system in the United States before, but we're developing one after the ACA.
So remember the argument that expanding Medicaid would affect Medicare? I don't see that happening. That was the argument in 2010, that it was going to ruin Medicare if we expanded Medicaid. All of these negative effects that our opponents are talking about haven't really come to fruition. And oh, by the way, we're in the minority of states that have not expanded Medicaid. Those other states are doing pretty well. So I want to talk a bit about Dr. Gorman's arguments and then circle back around and tell you a story about a friend of mine. Medicaid, so I showed you in my first speech that the private sector costs to people who have insurance are increasing because we failed to expand Medicaid in the state of Kansas, right? We're paying for it anyway. The state budget costs have been shown to be marginal, or in fact, Medicaid in many states has paid for itself. 80% of able-bodied adults enrolled on Medicaid in other states are working. There are a lot of low-income people who don't get health insurance with their job. We've given up $6.6 billion in federal money of taxes that we have paid and sent to Washington. $6.6 billion. I'd like that check, wouldn't you? It hasn't come back to the state. We would get, in 38 out of 40 states, taxes haven't increased for Medicaid expansion. Now I want to tell you about John. John lived in Lawrence, Kansas. He needed back surgery. He couldn't work. He was in constant pain. He moved to live with his family in California. His family signed him up for Medicaid because he was low income. He didn't qualify. He got his surgery. He is now working. In fact, he works in Colorado because he got access to the health care he needed and became a productive member of society. That's a win. Let's take it.
Please.
I would say a win for him would have been if he had health insurance in the first place. I would just talk about the DISH funds. There were no DISH funds or disproportionate share funds taken away from hospitals at all. It was in the ACA, all right, but they knew hospitals would not go for that, so every year they keep kicking that can down the road. Ask any hospital if they lost their disproportionate share funds or share for when people come into the emergency room and they don't have coverage. Another thing, I want to get back to the mom of three that I mentioned. I said I would come back to her. She would need to make about $27,800. Why? Because a family of four poverty level is not as low as an individual with poverty level. But when I checked with McDonald's yesterday, if you're a shift manager, and they told me to be a shift manager, just have to be a nice person, show up on time, and make sure we can count on you and be nice to the customers, and you could be a shift manager that pays $18 an hour. That's easy for her to get the $27,800, and her plans would have looked very much like the one I just showed you for the 27-year-old. I just want to close with, we've talked a lot about the ACA because the Medicaid expansion was part of the ACA. If any of you read my article that came out in the Wall Street Journal last week, would have known we're still talking about that, partially because of the promises that were made. I was writing policies for people before the ACA. I knew what was coming. I knew their rates were going to go up 400%. I knew only the low-income people were going to get the subsidies and everybody else was going to see astronomical premiums. I sat with those parents in their homes with their families crying, saying, what in the world are we going to do? We can't afford this. These rates have gone up. These are middle-income folks on a farm, and what were they going to do? I see head nods in the audience. So we had a promise from the ACA. The promise said $2,500 lower for every family Your premiums are going to go down by $2,500. We have the promise that you like your doctor, you can keep it. Last thing I'll just say is Medicaid Expansion has its same promises. Kansans are too smart to fall for an ACA promise again.
Ladies and gentlemen, would you please express appreciation to our debaters? Well, I think that's the fastest hour I have had in a long time. I want to invite you to two more events. Next week, same place, also at 5:30. We'll have candidate forum for the Leavenworth City Commission, followed by the school board. So we'll have both of those starting at 5:30 and then 6:40 for the school board. And then that's next Wednesday, and then the Friday after, on October 6th, we'll have a happy hour or a candidate meet and greet where you can come and meet the candidates, speak with them informally, and get to know your candidates for public office. And that'll be from 4 to 6 o'clock on Friday, October 6th at 10 and 2 Coffee Shop down in Lansing. Thank you. Thank you so much. This has been a wonderful event. You guys are marvelous. And let's go have dinner. Ladies and gentlemen.
I just want to clarify the statement that I made regarding your friend was that I like to see the cost of health insurance go down so that everybody could have insurance before they have a hurt back. That would be the ideal situation. Thank you.
Thank you for coming, ladies and gentlemen.